Good day, ma'am. Today, I will report about the non-pharmacological treatment and pharmacological treatment of dengue and hypertension. The non-pharmacological treatments of dengue are the following. First, drink plenty of fluids to prevent dehydration. Second, rest. And the third is soft, balanced, nutritious diet. First, drink plenty of fluids to prevent dehydration. Patients who have dengue fever should drink plenty of fluids, better if electrolytes contain fluid. Because as we all know, patient with dengue fever has a high body temperature and we tend to sweat more, so the fluids in our body tends to be lessened. And also fluids can help to regulate or maintain the homeostatic activity of our body. Second, rest. Patient must have enough rest for him or her to regain more energy. Third, soft, balanced, nutritious diet so that the patient's body can combat the infection present in his or her body system. Hypertension. Some non-pharmacological treatments are weight reduction, dietary salt reduction, adopt DASH type dietary plan, moderation of alcohol consumption, and physical activity. First is the weight reduction. So, attain and maintain a BMI of less than 25 kilograms per square meter. Prevention and treatment of obesity are important for reducing blood pressure and cardiovascular disease risk. In short term, trials, even modest weight loss, can lead to a reduction of blood pressure and an increase of insulin sensitivity. Average blood pressure reductions of 6.3 mmHg have been observed with a reduction in mean body weight of 9.2 kilograms. Regular physical activity facilitates weight loss, decreases blood pressure, and reduces the overall risk of cardiovascular disease. Blood pressure may be lowered by 30 minutes of moderately intense physical activity, such as brisk walking, 6 to 7 days a week, or by more intense, less frequent workouts. There is individual variability in the sensitivity of blood pressure to sodium chloride, and this variability may have a genetic basis. Based on results of meta-analysis, lowering of blood pressure by limiting daily sodium chloride intake of less than 6 grams sodium chloride per day results in blood pressure reductions of 3.7 to 4.9 mmHg in hypertensive and lesser reductions in normotensive individuals. Diets deficient in potassium, calcium, and magnesium are associated with higher blood pressures and a higher prevalence of hypertension. The urine sodium to potassium ratio is a stronger correlate of blood pressure than either sodium or potassium alone. Potassium and calcium supplementation have inconsistent, modest antihypertensive effects. And independent of blood pressure, potassium supplementation may be associated with reduced stroke morbidity, or mortality, I mean. Alcohol use in persons consuming 3 or more drinks per day, a standard drinks contains approximately 14 grams ethanol, is associated with higher blood pressures, and a reduction of alcohol consumption is associated with a reduction of blood pressure. Mechanisms by which dietary potassium, calcium, or alcohol may affect blood pressure have not been established. The DASH, or the Dietary Approaches to Stop Hypertension trial, convincingly demonstrated that over an 8-week period, a diet in high fruits, vegetables, and low-fat dairy products lowers blood pressure in individuals with high normal blood pressures or mild hypertension. Reduction of daily sodium chloride, like I said a while ago, intake to less than 6 grams, augmented the effect of this diet on blood pressure. Fruits and vegetables are enriched sources of potassium, magnesium, and fiber, and dairy products are important source of calcium. So next that I'll discuss is about the pharmacological treatments for dengue and hypertension. First, the pharmacological treatment for dengue are paracetamol or acetaminophen, H2 blockers or ranitidine, and domperidone. For paracetamol or acetaminophen is highly used over-the-counter drug for fever and for pain. So you can prescribe the patient with dengue fever of 500 milligrams every 4 hours until the body temperature goes back to its normal. And you should not prescribe aspirin containing drugs because aspirin, as we all know, it is an anticoagulant drug, and hence it can trigger epistaxis or mucopapillar rash. Second, H2 blockers. So H2 blockers like ranitidine is recommended in case of gastrointestinal bleeding. Ranitidine is a histamine H2 receptor antagonist that inhibits stomach acid production. It is commonly used in treatment of peptic ulcer disease and gastroesophageal reflux disease. So, medical use of ranitidine also relief of heartburn, acid indigestion, and sour stomach, gastroesophageal reflux or the GERD, erosive esophagitis, upper gastrointestinal bleeding, and others. The third is the domperidone. So, domperidone, you can prescribe 1 milligrams per kilogram per day in 3 divided doses in case of severe vomiting for 1 to 2 days. Next, for hypertension, We have the diuretics, blockers of renin-angiotensin system, aldosterone antagonists, beta blockers, adrenergic blockers, sympatholytic agents, calcium channel blockers, and direct vasodilators. So first that I'll discuss is about the diuretics for hypertensive patients. So diuretics. So diuretics, low-dose thiazide diuretics are often used as first-line agents alone or in combination with other antihypertensive drugs. Thiazides inhibit the sodium chloride pump in the distal convoluted tubule and hence increase sodium excretion. Long-term, they may also act as vasodilators. Thiazides are safe, efficacious, and inexpensive and reduce clinical events. They provide additive blood pressure lowering effects when combined with beta blockers, ACE inhibitors, or angiotensin receptor blockers. In contrast, addition of a diuretic to a calcium channel blocker is less effective. Usual doses of hydrochlorothiazide range from 6.25 to 50 milligrams per day. Owing to an increased incidence of metabolic side effects like hypokalemia, insulin resistance, increased cholesterol, higher doses are generally not recommended. 2 potassium-sparing diuretics, amiloride and triamterene, act by inhibiting epithelial sodium channels in the distal nephron. These agents are weak antihypertensive agents but may be used in combination with a thiazide to protect against hypokalemia. The main pharmacologic target for loop diuretics is the sodium-potassium chloride co-transporter in the thick ascending limb of the loop of Henle. Loop diuretics are generally reserved for hypertensive patients with reduced glomerular filtration rates. CHF, or the cardiovascular heart failure, or sodium retention and edema for some other reasons such as treatment with a potent vasodilator. For example, is the minoxidil. Second is the blockers of renin-angiotensin system. ACE inhibitors decrease the production of angiotensin II, increase bradykinin levels, and reduce sympathetic nervous system activity. Angiotensin II receptor blockers provide selective blockade of angiotensin I receptors, and the effect of angiotensin II on unblocked angiotensin II receptors may augment the hypotensive effect. Both classes of agents are effective antihypertensive agents that may be used as monotherapy or in combination with diuretics, calcium antagonists, and alpha-blocking agents. Side effects of ACE inhibitors and angiotensin receptor blockers include functional renal insufficiency due to efferent renal arteriolar dilatation in a kidney with a stenotic lesion of the renal artery. Additional predisposing conditions to renal insufficiency induced by their agents include dehydration, cardiovascular heart failure, and use of non-steroidal anti-inflammatory drugs. Dry cough occurs in approximately 15% of patients, and angioedema occurs in less than 1% of patients taking ACE inhibitors. Angioedema occurs most commonly in individuals of Asian origin and more commonly in African Americans. Hyperkalemia due to hypoaldosteronism is an occasional side effect of both ACE inhibitors and angiotensin receptor blockers. Next is aldosterone antagonist. So, aldosterone antagonists, spironolactone is a non-selective aldosterone antagonist that may be used alone or in combination with a thiazide diuretic. It may be a particularly effective agent in patients with low renin essential hypertension, resistant hypertension, and primary aldosteronism. In patients with CHF, low-dose spironolactone reduces mortality and hospitalizations for heart failure when given in addition to conventional therapy with ACE inhibitors, digoxin, and loop diuretics. Because spironolactone binds to progesterone and androgen receptors, side effects may include gynecomastia, impotence, and menstrual abnormalities. These side effects are circumvented by a newer agent, eplerenone, which is selective aldosterone antagonist. Eplerenone has recently been approved in the United States for the treatment of hypertension. So next is the beta blockers. Beta adrenergic receptor blockers lower blood pressure by decreasing cardiac output due to a reduction of heart rate and contractility. Other proposed mechanisms by which beta blockers lower blood pressure include a central nervous system effect and inhibition of renin release. Beta blockers are particularly effective in hypertensive patients with tachycardia, and their hypotensive potency is enhanced by co-administration with a diuretic. In lower doses, some beta blockers selectively inhibit cardiac beta-1 receptors and have less influence on beta-2 receptors on bronchial and vascular smooth muscle cells. However, there seems to be no difference in the anti-hypertensive potencies of cardioselective and non-selective beta blockers. Certain beta blockers have intrinsic sympathomimetic activity, and it is uncertain whether this constitutes an overall advantage or disadvantage in cardiac therapy. Beta blockers without intrinsic sympathomimetic activity decrease the rate of sudden death, overall mortality, and recurrent myocardial infarction. In patients with CHF, beta blockers have been shown to reduce the risks of hospitalization and mortality. Carvedilol and labetalol block both beta receptors and peripheral alpha adrenergic receptors. The potential advantages of combined beta and alpha adrenergic blockade in treating hypertension remain to be determined. So next is the alpha adrenergic blockers. Postsynaptic selective alpha adrenoreceptor antagonists lower blood pressure by decreasing peripheral vascular resistance. They are effective antihypertensive agents used either as monotherapy or in combination with other agents. However, in clinical trials of hypertensive agents, alpha blockade has not been shown to reduce cardiovascular morbidity and mortality or to provide as much protection against CHF as other classes of antihypertensive agents. These agents are also effective in treating lower urinary tract symptoms in men with prostatic hypertrophy. Non-selective alpha adrenoreceptor antagonists bind to postsynaptic and presynaptic receptors and are primarily used for the management of patients with pheochromocytoma. Next is symphytolytic agents. Symphytolytic agents, centrally acting alpha-2 sympathetic agonists, decrease peripheral resistance by inhibiting sympathetic outflow. They may be particularly useful in patients with autonomic neuropathy who have wide variations in blood pressure due to baroreceptor denervation. Drawbacks include somnolence, dry mouth, and rebound hypertension on withdrawal. Peripheral symphytolytics decrease peripheral resistance and venous constriction by depleting nerve terminal norepinephrine. Although potentially effective antihypertensive agents, their usefulness is limited by orthostatic hypotension, sexual dysfunction, and numerous drug-to-drug interactions. Next is the calcium channel blockers. Calcium antagonists reduce vascular resistance through L-channel blockade, which reduces intracellular calcium and blunts vasoconstriction. This is a heterogeneous group of agents that includes drugs in the following three classes. First is the phenylalkylamines. Second is the benzodiazepines. And the third is 1,4-dihydropyridines. Used alone and in combination with other agents like the ACE inhibitors, beta blockers, alpha-1 adrenergic blockers, calcium antagonists effectively lower blood pressure. However, it is unclear if adding an adiuretic to a calcium blocker results in a further lowering of blood pressure. Side effects of flushing, headache, and edema with dihydropyridine use as related to their potencies as arteriolar dilators. Edema is due to an increase in transcapillary pressure gradients, not to net salt and water retention. And the last is the direct vasodilators. Direct vasodilators. These agents decrease peripheral resistance and concomitantly activate mechanisms that defend arterial pressure, notably the sympathetic nervous system. The renin-angiotensin angiotensin-aldosterone system, and the sodium retention. Usually, they are not considered first-line agents, but are most effective when added to a combination that includes a diuretic and a beta blocker. Hydralazine is a potent direct vasodilator that has an antioxidant and nitric oxide enhancing actions, and minoxidil is a particularly potent agent and is most frequently used in patients with renal insufficiency who are refractory to all other drugs. Hydralazine may include a lupus-like syndrome, and side effects of minoxidil include hypertrichosis and pericardial effusion. So these are the examples of oral drugs used in treatment in hypertension. So the drug classes indicate like the diuretics that I mentioned a while ago, the beta blockers, alpha antagonists, and the others. So there are examples like the diuretics. Example is the hydrochlorothiazide, which has the usual total daily dose or dosing frequency per day of 6.25 to 50 milligrams, 1 to 2 days, and unindicated contraindications or cautions like diabetes, dyslipidemia, hyperuricemia, gout, and hypokalemia. So example and the others. And an example also of beta blockers are the atenolol, metoprolol, propranolol. So for atenolol, the dosing frequency per day is 25 to 100 milligrams per day. So other indications for angina and CHF, and contraindications for asthma with COPD, second or third degree heart block, and sick sinus syndrome. And the others, like for example, the calcium, like the ACE inhibitors, example such as the captopril, lisinopril, ramipril. So for dosing frequency per day of captopril is 25 to 200 milligrams for 2 days. Other indications for post myocardial infarction, CHF, and nephropathy. And contraindications of captopril are renal failure, bilateral renal artery stenosis, pregnancy, hyperkalemia. And for direct vasodilators, example is hydralazine, minoxidil. For minoxidil, the dosing frequency per day is 2.5 to 80 milligrams, 1 to 2 days. And contraindications for severe coronary artery disease. So that's all, ma'am. Thank you po. God bless and have a nice sem break po. Thank you very much po.